Hi folks, it's Rob Timmings from ECT for Health. Welcome back to another one of our KYJs. I thought I'd do something a little bit different with this. I thought I'd do it as a video. So I want to talk about pneumonia. It's National Pneumonia Week. We are on in the second week of May, third week of May now, 2021. So it's our third week of May, and it's National Pneumonia Week. And I thought I'd do a very quick little video, maybe no more than 10 minutes, just on pneumonia. What is pneumonia? So let's get started. First of all, I want to look at a little bit of physiology. So there's going to be for the geeky anatomy nerds that are watching the post, then I'd like to think that there was something in it for you. So we're going to do some pathophysiology around pneumonia, and of course we'll have a look at some anatomy and physiology around the alveoli and gas exchange, just very, very briefly. A little bit of epidemiology, tiny little bit of epidemiology, and touch on really where pneumonia and chest infection dovetail. Because I guess the biggest take-home message, in fact, if there was a take-home message from this session, and that is stop thinking that pneumonia is a chest infection, because it's not. Pneumonia is not a chest infection, and a chest infection is not pneumonia. Pneumonia is a symptom of some chest infections, sure, but they're not one and the same. And I'm hoping by the end of this 5 or 10 minutes that you really understand that you can embrace that notion that pneumonia is not a chest infection. The words shouldn't be interchangeably used. Certainly chest infection is the most common cause of pneumonia. There's no question that it is a common cause of pneumonia, but they aren't one and the same. If we had a look at chest infection statistics, ultimately deaths from chest infections occur with pneumonia on board. So people who die from chest infection often also will die with pneumonia, because it's kind of like the end of the line when it comes to the badness that occurs from severe chest infections. We lose about on average about 2,500 Australians a year from chest infection. Women are overrepresented and Indigenous Australians are overrepresented. But if we have a look at pneumonia-like illnesses, whilst pneumonia is very much a very, very deadly syndrome attached to chest infections, perhaps, really only about 10% of people with pneumonia at any one time are going to be hospitalised. About 90% of people with pneumonia in its mildest form are actually treated quite successfully at home. They tend to be a non-hospitalisation approach. It's only that sort of top 10 or the worst 10% is what we see. So a definition of pneumonia then, it's an acute inflammatory disorder. So pneumonia is about inflammation. And what happens is that in the context of the inflammation that causes pneumonia, that inflammation is in the same location that usually there is chest infection present. So anything that's going to cause inflammation within your alveolus, within your alveoli, potentially could cause you to develop pneumonia. So a euphemistic term for pneumonia is probably more correctly, it's pneumonitis, in other words, inflammation of the lung. And right there, you can see that if inflammation of the lung is what pneumonia is, it's reasonable to assume that I could have inflammation in my lung without necessarily having a chest infection. So it's possible that I could have pneumonia, but no infective process going on. We'll explain a little bit further in a minute. Pneumonia causes a lack of surfactant to be produced. And really that is the guts of the pathophysiology. It's a lack of surfactant. When I have a reduction in surfactant, my alveolus loses its compliance. It becomes less elastic, like a balloon. It becomes more brittle. It becomes more leaky, so it can develop fluid exudate. And its overall capacity to be able to expand and contribute to gas exchange becomes altered. A lack of surfactant leads to collapse of the alveoli, and this is referred to as atelectasis. So atelectasis is collapsing of the alveoli. Commonly, infection is the most common cause. Cough is nearly always present with pneumonia. Plus or minus infection, cough is nearly always present, and there's nearly always some sort of a cough that is sputum producing. So it's a wet cough. It may be a clear to cream colored sputum. It may be an infective looking yellow or green sputum, but ultimately there's always a cough associated with pneumonia. Chest pain is really quite common with pneumonia. It is an inflammatory disorder, and as we know, chemicals that are released during the inflammatory process cause pain. And so pneumonia will be no different. A patient will have a sore chest, whether they're coughing or not. Pneumonia is in and of itself painful. The hallmark of the development of badness when it comes to pneumonia is the desaturation process, when somebody starts to drop their ability to be able to gas exchange adequately. There's a number of causes for pneumonia, and I guess, as we've said, the most common cause is infective. So viruses make up probably about 90% of our pneumonias, followed closely by bacteria at around about 5% of our pneumonias are bacteria. So when we have a look at viruses and bacteria, there's 95% of the reason why we would have pneumonia. To a much, much lesser extent, fungal organisms, so fungus can cause pneumonia, and sort of fungal disorders that we might see are in immunocompromised patients who have maybe HIV, developing AIDS, or are immunocompromised secondary to chemotherapy recipients, or patients who are immunocompromised because they're on medications that are immunosuppressive. So the types of fungus that we see in these patients and parasitic organisms that we see manifest in these patients are things like Pneumocystis jirovecii that causes the PCP pneumonia that we see in patients with an acquired immunodeficiency syndrome. Cryptococcus and toxoplasmosis is probably the most common parasitic organism that we see in lungs. Aspiration of foreign matter. If you were to, let your milkshake go down the wrong hole, if you had a near drowning and your lung filled up with some sort of, salt or fresh water from swimming in a water hole, then that in and of itself can cause damage to the lung that leads to a pneumonia. Can you see there's no chest infection present? Inhalation of damaging gases, smelling things like chlorine gas, or the gas that's emitted from hydrochloric acid, or some of those very, very noxious gases that can actually cause injury to the respiratory tree. And then, of course, there's lung trauma, things like barotrauma or pressure injury, maybe from overzealous ventilation or bagging of a patient when we're using the bag valve mask. Other things like blunt or penetrating chest injuries can certainly lead to a pneumonia, as we have an inflammatory injury process going on. And then one that's not listed there is actually the pneumonia that we might see in a premature baby. Below the age of about 33 weeks gestation, a baby's lungs haven't started to produce surfactant yet. So they're essentially fundamentally born with pneumonia. They're born with a lack of surfactant, giving rise to a large number of their alveoli not being able to be lubricated with that surfactant to prop open and to pop open. So let's have a look at a lung sort of alveolus in closer detail. We'll zoom right in. What we've actually got here up on screen is just one of maybe the 700 million alveoli that you have. You're born with about 400 million. You grow them up to about 700 million by the time you're 20 years of age. And then they start to disintegrate. Alveoli sort of disintegrate and break down over your lifespan. By the time you're 80, your lung capacity is probably only about 50% of what it was when you were 20. So anything you do to destroy your alveoli, stop doing it, because you need them. They don't grow back in a hurry. So this is a typical alveolus, and it's made up of really two sort of structural cells. This is a very oversimplified diagram, but I'm hoping that you can see that the capillary at the bottom, the blood vessel at the bottom, is a single cell thick. Then we've got this area here in the middle, and it's this area in the middle that's referred to as the respiratory membrane. So I'm just going to abbreviate that to RM. And this is where the gas exchange takes place. Oxygen moves from the alveolus that you've just breathed in some air into the bloodstream. And of course, carbon dioxide, CO2, is going to move in the opposite direction. If we have a look at the two cells that are dominating this, alveolus, you can see this little green guy here. He is called the type 2 pneumocyte. I'm just going to abbreviate it to type T2P, the type 2 pneumocyte. And this one here, this is the squamous pneumocyte, or the type 1 pneumocyte. So two types of cells that make up the elastic bag that is your gas sac, your alveolus. The role of our type 1 pneumocyte is structure. It's really there to be the walls of your lung sacs, your air sacs. But the type 2 pneumocyte, it has many, many roles, and one most important role of the type 2 pneumocyte, the great alveolar cell is the other name for it, is the production of that substance called surfactant. Surfactant. So surfactant is produced by the lung from about 33 weeks gestation. Now, the premise of any injury is that your body will try and repair itself. So anytime that you have an injury inside your lung, like everywhere else in your body will mount a repair sequence of events. And that sequence of events usually starts with stopping any bleeding, if there is any bleeding. We'll call that hemostasis. The second thing that your body starts to do is this process called inflammation. So there's an inflammatory process that is mounted in response to an injury. And then the third thing that happens is the tissue repair. So I know that takes us right back to basic sort of wound healing theory. But at the end of the day, it's no different when you have an injury to your lung. You're going to mount an immune response in response to the injury. Because you have mounted an immune response, healthy tissue that has been damaged ceases to function. So I want you to imagine now that on the inside of this alveolus, I'm just going to change the color to a nice purple color. There we go. On the inside of the alveolus, we've got this bacteria. There he is, this little bacteria with his funny little tail. He's going to start to secrete these substances that physically cause damage and destruction to these alveolar type 1 and type 2 cells. Can you see that if it's a bacteria, it's releasing some sort of a toxin that causes damage? If it's a virus, it actually invades these lung cells and it sort of kills them from the inside. If it's something that you've inhaled, like a noxious gas, or you've inhaled some seawater when you had when you were dumped in the surf, or for whatever reason, something that causes injury down here, the first step is that we're going to have an injury, a process where we have injury is produced. And that injury will always lead to inflammation. Now, during inflammation, the tissues that are inflamed, which in this case is the lung, cease to function. So if the function of our type 1 pneumocytes is to be flexible, they become stiff. If the function of the type 2 pneumocytes is to produce surfactant, they stop making surfactant. So now we have a stiffened alveolus that's in a state of inflammation, and we have an alveolus that loses that lubricating surfactant layer that's around the inside. This is the surfactant sort of gets secreted around the inside, but that ceases. So now my alveolus can actually collapse like a wet balloon, and it becomes more difficult to pop open with my next breath. The more and more alveoli that become collapsed, that undergo that atelectasis, the more and more deficit to my gas exchange I have. So we have, first of all, this inflammation. Then we have this decrease in surfactant production. So my surfactant production decreases. Then my alveolus becomes very tight and tense. It becomes stiffened. So I get a tension in my alveolus. Then I get collapse of my alveolus. This is referred to as atelectasis. And only then, as a result of the inflammatory cascade, do we start to get a shifting of fluid, and plasma starts to move in, and these cells start to break down and disintegrate, and enzymes start working on them, and a whole lot of exudate and muck now starts to build up. And we'll call that purulent exudate, starts to build up on the inside of this alveolus. We're going to get an increase of fluid start to leak and move into this space between the capillary and the lung, and that causes an overall reduction, that toxic exudate. Let's just change that color back to where we were. That toxic exudate causes an overall reduction in oxygen delivery. And this is where the patient desaturates. So you can see that that's formed the abbreviation ISTAT. And I like to teach with abbreviations. It's how I roll. That's how I remember stuff. So what have we got going on with our pathophysiology in our alveolus? We've got an injury that leads to an immune response. Those macrophages, part of the white blood cell cleanup team, the macrophages move into the lung and start cleaning up debris. And as they do that, they induce a number of chemicals, or they release a number of chemicals. And this is referred to as the cytokine storm. So you may have heard of the cytokine storm that is characteristic of somebody with pneumonia, or characteristic of somebody that has COVID. Not that this is a session about COVID. Surfactant production ceases completely. So that step occurs. Then the alveoli becomes stiffened and hardened and tortuous. It starts to collapse. That's called atelectasis. Large amounts of atelectasis are called consolidation. You've probably heard the term left lower lobe pneumonia, or left lower lobe consolidation, or right middle lobe consolidation. That's a massive widespread atelectasis that's occurring. And then the lung starts to fill up with toxic exudate that causes a change in not only polarity, but also a change in osmolality. So that muck that's building up on the inside of that person's lungs starts to attract water. And as it drags water towards it, the lungs fill up with fluid. So you've got this combination, this sort of dichotomy of this paradoxical process where you've got some alveoli are collapsing and shrinking, and you've got other alveoli that are becoming congested and filled up with exudate. That whole process, that is in a nutshell what our pneumonia is. Diagnosis of pneumonia is fairly straightforward. It's based on history. Patients coming in with a cough, they're tired, they're exhausted, they're desaturated. We're going to do a set of vital signs. We may find that their saturations are below 90% on room air. On auscultation, when we're listening to somebody's chest, some interesting things with a stethoscope can be heard. We certainly hear a reduction in air entry over the lobe of the lung where the pneumonia is most prevalent. But we can also hear a density as the lung starts to fill up with this consolidated matter, this muck. Then an interesting phenomena that allows for us to be able to hear the patient through the stethoscope while they whisper. You might want to Google that. It's called whispering pectroquili. It's quite interesting, placing a stethoscope over an area where somebody's got pneumonia in their lung. What we will actually hear is their voice when they whisper. You normally can't hear a whisper with a stethoscope. I know you're going to rush out there and try it. It's the coolest thing ever. The blood tests, well, depending on what the cause is, we may see an inflammatory process. So CRP may be elevated in acute inflammation. CRP, C-reactive protein, goes up. If somebody's got an infective process going on, we may see an elevation in neutrophils. So normally neutrophils make up about 60% of your white blood cells, 65% of your white blood cells. So if they start to suddenly dramatically rise, then that's a high index of suspicion that that patient's got an infective process going on, and that infection is more likely to be something pathological like a bacteria or a fungal infection. And electrolytes can start to shift as well. That tends to happen a lot later in the process. If we're going to do a sputum culture on a person, remember that doesn't change management. Right now, if somebody's coming in with a chest infection, we want to treat them today. We don't want to wait 3 or 4 days for their sputum culture to come back. Really, that's just covering all bases. We would probably, if they've got an infective pneumonia, place them onto antibiotics early. And then we'll check back with the sputum culture to see what it grows in the laboratory to make sure that we're giving the correct antibiotics. So that's really the fundamentals of it. For viral pneumonias, it's supportive management. The use of anti-inflammatory medications like dexamethasone and prednisone and budesonide and hydrocortisone, anti-inflammatories, the steroidal anti-inflammatory medications, is certainly well established, and we absolutely do it with viral chest infections, or viral pneumonias, I should say. And the reason for that is because it's the inflammation that's causing the shutting down of the surfactant. It's the inflammatory process that's killing the patient. If we can shut down that inflammation, there is a chance that the monumental cytokine storm is going to be less likely to cause harm. When we have a look at chest x-rays, we can see the area of density and opacity on their chest x-ray. So I'm hoping that you don't need to be a radiologist or a radiographer to recognize the big consolidated mass that's in this patient's right upper lobe. Right middle lobe. Okay, so that's pretty much it. Pneumonia is not a chest infection, but it's absolutely a pathology that is seen and coexists with chest infections. That went way more than 5 to 10 minutes. If you're still with me, fantastic. Thank you so much. My name's Rob Timmings. You've been listening to another very quick video. I'd like to think it was a very quick video on pneumonia. Good for about 20 minutes of CPD. Alrighty. I'll see you later, folks. Thanks for joining me, and happy Pneumonia Week. Cough, cough.